It is my tremendous honor to be invited to give a talk at this conference. I'm Alex Lowe from the National Taiwan University Hospital. Today, I'm going to talk about the treatment outcomes and prognosticators of oral cavity cancer. As you may see, the incidence of oral cavity cancer in Taiwan is very high. On your left-hand side, you see the global scan data. The male plus female incidence of oropharynx and hypopharyngeal cancer ranked number 2 in the whole world. But if you see the oral cavity cancer, the incidence of oral cavity cancer, Taiwan ranked number 1 in the world. So this is a very, very serious disease burden to Taiwanese people. The main cause of oral cavity cancer in the Western country is cigarette smoking and alcohol drinking. However, in Taiwan, there is another very important carcinogenic factor, which is the betel quid chewing. This is the betel nut. We have many kinds of betel to be used by our people. And a couple of years ago, we performed a cohort study to study the risks of developing oral cancer in habitual alcohol, betel nut, and cigarette users. And from 1982 to 1992, we enrolled more than 2,500 men enrolled. The mean duration of follow-up is roughly around 20 years. Actually, it's 18.4 years. And during the follow-up, there were 269 cases of upper aerodigestive tract cancers were newly diagnosed. The follow-up of 472 person years. So the calculated overall incidence rate of upper aerodigestive tract cancer in Taiwanese male is 57 per 100,000 years, which is very, very high. And the multivariate adjusted hazard ratio, we can see betel quid chewing is the main cause of oral cavity cancer and pharyngeal cancer and esophageal cancer. And cigarette smoking is a carcinogenic factor for oral cavity cancer, pharyngeal cancer, esophageal cancer, and laryngeal cancer. And alcohol drinking, surprisingly, is not a main cause of oral cavity cancer in Taiwan. However, it's related to pharyngeal cancer, esophageal cancer, and laryngeal cancer. So this is the incidence adjusted hazard ratio. You can see if you ever drink alcohol, and the risk is actually not very high. But if you smoke, then you can see the lifetime risk of developing upper aerodigestive tract cancer is 1.56. And if you chew betel, then it increased to 4.65. And if you have cigarette smoking and alcohol drinking, then the lifetime risk is 3.94. And betel quid plus alcohol is 8.6. And betel quid plus cigarette smoking is 8.8. And if you use 3 betel, cigarette, and alcohol, the lifetime risk is 12. So the lifetime risk increased with the increase of the adverse habits. And because the carcinogenic factor in the Western countries and in Taiwan are different, so the next question we want to ask is, what are the molecular signatures of oral cavity cancer in Taiwan? Is it different from the TCGA database? So we analyzed more than 300 oral cavity cancer patients, and we performed whole exome sequencing from fresh tumor samples. And actually, the rank of the mutated genes between Taiwanese oral cavity cancer and the TCGA database, the rank are roughly similar. However, there's a very unique ApoBac3B mutation observed in Taiwanese oral cavity cancer patients, which is could be observed in about 50% in our Taiwanese patient, as compared with about 6% in the TCGA database. And those with wild type ApoBac3B have worse prognosis, overall survival, as compared with those with mutation. And this is the wild type, and this is the mutation, and better prognosis in patients with ApoBac3B mutation can be observed. And P53 mutation, FAT1, NOTCH1, PIK3 kinase, and CDKN2A are the most commonly mutated genes in Taiwanese oral cavity cancer tumors. And we want to compare our data, our survival data, our Taiwan Cancer Registry survival data with the US SEER database. And so we recruited our oral cavity cancer patients, and from 2010 to 2016, the database consists of about 23 million Taiwanese patients, and the population for the SEER database is about 100 million. And you can see during the 7 years period, we have 3,400 oral cavity cancer patients, as compared with 3,900 oral cavity cancers in the United States. And the survival, the all-stage survival, roughly the blue bar represents the SEER database, the red bar represents our Taiwan Cancer Research database. In general, the all-stage survival our survival slightly worse than in the United States. For stage 1 disease, roughly the same. For stage 2 disease, actually, we're doing better than the SEER database. And in stage 3, roughly the same. What we are doing worse than the Americans are the stage 4, those with stage 4 disease, especially those with M1 disease, probably is due to the introduction of immunotherapy in the United States between the 2010 and 2016, and we didn't have this kind of a treatment in our country during that time. So what are the prognosticators for oral cavity cancer? And we recruited our database from our hospital from 2004 to 2009, total of 1,288 oral cavity cancer cases. The survival for stage 1 disease and stage 2 disease is over 85%. For stage 3 disease is about 76%. And for stage 4 disease, about 55%. So the risk factors for T1, T2, and 0 cases. And this is a multivariate analysis, and we can see tumor differentiation and major risk factor, which is the positive margin, are the main risk factors for those with T1, T2, and 0 disease. You can see the well-differentiated tumor have better disease-free survival and also overall survival as compared with those with poorly differentiated tumors. And poorly differentiated tumors are associated with poor survival and higher distant metastasis rate in early stage patients. And if those the patients with T1, T2, and 0 disease, and after the surgery, the pathology, we have a close margin. How about the outcome of these patients? So you can see those with positive margin the survival are worse than those with clear margin, and actually those with close margin are with a worse survival as compared with those with clear margin. And you can see those with clear margin, the survival with close margin are doing worse. So pathology close margin is associated with a poor survival in early stage patients, especially in patients with a perineural invasion and lymphovascular invasion. In patients without perineural invasion and lymphovascular invasion, the survival are almost the same in those with close margin and clear margin. And how about the minor risk factor, the perineural invasion and lymphovascular invasion, and the outcomes of early stage cancer patients? So the group A is those without perineural invasion or lymphovascular invasion. The group B are those with perineural invasion and or lymphovascular invasion. Actually, perineural invasion and lymphovascular invasion were not significant risk factors for disease control and overall survival for stage 1 and stage 2 oral cavity cancer patients. And at that time, we don't know whether these kind of patients should receive postoperative radiotherapy or not. So we did analysis and we found that actually the survival with or without postoperative radiotherapy were the same. And postoperative radiotherapy could not provide additional benefit on disease control and overall survivals for stage 1 and stage 2 oral cavity cancer with perineural invasion and or lymphovascular invasion. And how about those with N1 disease? Shall we perform adjuvant radiotherapy? And we recruited tongue cancer patients and more than 200 tongue cancer patients. And we find that adjuvant radiotherapy can provide better disease-free survival, but not overall survival for pathology T1, T2, N1 tongue cancer patients. And now we go to the stage 3 and stage 4 patients. We do a multivariate analysis to see the risk factors for these stage 3 and stage 4 patients. The first one, of course, the stage, pathological stage, stage 4 cases had a worse survival. And the end stage, those with N2C advanced nodal disease will have worse survival. And differentiation, poorly differentiated tumor, patient with poorly differentiated tumor will have a worse survival. And of course, margin status, a positive margin or close margin patients will have a worse survival. And extranodal extension of the lymph node metastasis is also independent prognosticators for stage 3 and stage 4 disease. And you can see patient with bilateral neck metastasis. This is unilateral metastasis, and without neck metastasis, bilateral neck metastasis is associated with poor survival in oral cancer patients. And tumor differentiation, poorly differentiated tumors is associated with poor survival in stage 3 and stage 4 patients. And sometimes when we perform the operation, our margin, sometimes the pathology report will tell us it's with dysplasia. So we want to see is the disease-free survival and overall survival will be impacted by the dysplasia in our surgical margins. So we analyzed our database of 1,600 cases, and we found that disease-free survival and overall survival were not significantly different in patients with dysplastic and clear margins. And adjuvant radiotherapy actually provides worse survival in patients with dysplastic margins. Maybe it's due to the side effect of radiotherapy. And multivariate analysis, we can see the positive margin and extranodal extension are the independent prognostic factor, whether but dysplastic margin are not an independent risk factor for disease-free survival and overall survival. And how about the definition of the clear margin? And this is a topic of long-lasting debate, and many papers with different case numbers that are discussing what is the clear margin for oral cavity cancer. So we recruit our Taiwan Cancer Registry database, and finally we get 15,000, more than 50,000 cases of oral cavity cancer. And you can see the analysis showed the majority of the patients are male, and buccal and tongue cancer are the most common location, subsites of our oral cavity cancer. And this is the stage distribution of our patients. And actually, male patients had slightly worse survival as compared with the female patients. Patient with older age, palatal cancer, and poorly differentiated tumor, and T3, T4 disease. These are the independent prognostic factors for our oral cavity cancer patients. And what is more important is that if the margin is more than 4 millimeters, the patients will have a better cancer-specific survival. So surgical margins of more than 4 millimeters is adequate for favorable cancer-specific survival in patients with oral cavity cancer. You can see this is a remarkable difference in those without a clear margin, which is defined by 4 millimeters. And finally, I want to talk some of other biomarkers identified in our lab. And we know that aberrant glycan code is a hallmark of cancers. During the carcinogenesis process, many aberrant glycan code can be identified in the cancer tissue. You can see this is a normal oral mucosa, an early invasive cancer, well-differentiated cancer, and poorly differentiated. In cancer tissues, the expression of Tn and T antigens, these are the glycan codes, can be observed to be overexpressed in cancer tissues as compared in the adjacent non-tumor mucosa tissues. And we also identify several O-glycotransferases are upregulated in oral cavity cancer. You can see Western blot in the tumor tissue, and they're all overexpressed. And immunohistochemistry stain also overexpressed in the cancer tissues. So when we overexpress one of the O-glycotransferase called GalNAc2, the migration and invasion of the tumor increased. And when we knock out, the invasion and migration can be suppressed. And the mechanism is due to the GalNAc2 modify the phosphorylation of EGFR. And this could relate, because of the phosphorylation of EGFR, the tumor will become more invasive and more aggressive. And another O-glycotransferase, this is C1-GLT1, is overexpressed in the tumor tissues as compared with normal tissues of oral cavity cancer. And we look at the public database. These can be also observed in many public database. And immunohistochemically, overexpression of C1-GLT1 is associated with worse disease-free survival and overall survival of oral cavity cancer patients. And mechanism, this is very complicated. In short, overexpression of C1-GLT1 also will modify the phosphorylation of EGFR and induce the malignant transformation and malignant phenotype in oral cavity cancer and other type of head and neck cancer cells. And these are the overexpressed O-glycotransferase. So we look at the promoter using the software analysis, and we find that GATA3 is a common transcription factor in the in their promoter. So we see the public database, yes, GATA3 is overexpressed in many head and neck cancers, and you are in our oral cavity cancer specimen, GATA3 is overexpressed in our oral cavity cancer specimen as compared with a normal tumor and normal tissues. And immunohistochemically, overexpression of GATA3 is associated with worse disease-free survival and also overall survival in the oral cavity cancer patients. And the mechanism in normal condition, HIF-1 alpha is ubiquitinated in the cytosol to be degraded. But in cases with overexpression of GATA3, it will stabilize HIF-1 alpha and perform a nuclear translocation to trigger downstream HIF-1 alpha associated genes to be involved in angiogenesis, tumor growth, invasion, and metastasis. And these, we publish these results in some of the journals. And in the future, we are still looking for the biomarkers for malignant transformation of oral cavity cancer from the normal oral mucosa to dysplasia to invasive cancer. And we're also looking for biomarkers for immunotherapy. And more importantly, we are looking for actionable biomarkers. And with that, I would like to thank you for your attention and wish you a safe and peaceful 2023. Thank you very much. Thank you.